So chapter 37, still in pediatric cardiac, we're going to talk about iron deficiency anemia. So this is the most common type of anemia and the most common nutritional deficiency in children. You'll see with infants, a lot of times the newborn has that high hemoglobin level needed during fetal life to bring those high levels of oxygen. Remember, they don't use their lungs, so they have a whole lot of red blood cells. However, afterwards, when they start using their lungs, they have to get rid of that. The huge decrease in those first 2 to 3 months. Considerable iron reclaimed, restored, however, usually in sufficient quantities to last for 4 to 9 months. At this point, a child, as soon as they kind of get a little bit older, a child is going to need to absorb anywhere from 0.8 to 1.5 milligrams of iron per day. And because only 10% of that dietary iron is absorbed, they're going to have a diet of 8 to 10 milligrams of iron just to remain healthy. So sometimes that can be a little difficult for kids. The body does require iron for the production of hemoglobin. Insufficient qualities of iron limit the hemoglobin production, which affects the production of red blood cells. Red blood cells are, of course, needed to carry oxygen throughout the body. Prolonged anemia can lead to growth retardation and developmental delays. So after 6 months, infants who do not take appropriate solid food and are breastfeeding or taking formula without iron are at risk for becoming iron deficient because of the depletion of neonatal iron stores. So some parents wanted to do breastfeeding only. They need to know, however, that the breast milk is no longer sufficient in that. Neonates have those iron stores, but by 6 months, they need something more. And that's when we start introducing iron, fortified iron cereal, rice cereal. So it has the iron in that rice cereal. Excessive intake of cow's milk in toddlers can also lead to iron deficiency. So a lot of moms think that the milk is the best product, the best food for your baby. However, you can have babies who are taking whole milk and seem super, super chubby, but they're actually not healthy. Whole milk is not a good source of iron, and there is a substance in the milk that actually binds with iron and interferes with absorption. So it can actually be a bad thing. Assessment, a lot of times you're going to see their pallor, shortness of breath, fatigue, muscle weakness, poor muscle development, irritability, height, weight, growth retardation, and developmental delays. They'll have nail bed deformities, tachycardia, decreased serum ferritin levels, which show low iron store levels. And then they can also have those low hemoglobin levels. Whenever you're looking at your labs, you probably have seen an MCV and a serum iron binding capacity. All of that indicates low iron levels. So the hemoglobin less than 11 grams or hematocrit of less than 33% equals iron deficient anemia. Dietary management is preferred long-term treatment for iron deficient anemia. We want to introduce iron-rich foods, organ meats, which good luck getting a kid eating that, right? Dried legumes, nuts, green vegetables, and any kind of iron-enriched flours. You see a lot of cereals that are iron-enriched. We want to promote rest, protect from infection, monitor cardiac functioning. Medications, we can give them iron. Iron is best absorbed on an empty stomach. Vitamin C, such as orange juice, will promote iron absorption. Milk and antacids are going to inhibit it. So watch out for those NCLEX test questions that ask you, basically ask what you should allow the child to drink while taking that iron supplement. They'll try and trick you and put milk, but we know that it needs to be vitamin C. It's going to help absorb and promote that absorption. Oral iron preparations can stain the teeth, so they might also ask you a question about whether or not you let the child drink it, or if you introduce it through a straw. They need to use a straw and have the child brush their teeth immediately after taking that medication. Ferrous sulfate corrects anemia caused by iron deficiency, iron dextrane mixture impluron. It is an IM injection. It can be irritating, but that's one way to correct it as well. And then all iron medications should be kept out of the reach of children. Iron overdoses can be fatal, so we need to make sure we're locking those up. So here's another question. The nurse is reinforcing teaching with a group of caregivers of a child diagnosed with iron deficiency anemia. One of the caregivers tells the group, I give my child ferrous sulfate. Which of the following statements made by the caregivers is correct regarding giving ferrous sulfate? A. When I give my son ferrous sulfate, I know he needs potassium supplements. B. I always give the ferrous sulfate with meals. My husband, C, gives our daughter orange juice when she takes her ferrous sulfate, so she gets enough vitamin C. And D. We watch closely for any diarrhea, since that usually happens when he takes ferrous sulfate. Okay, so which statement made by the caregiver is correct in regarding giving ferrous sulfate? The answer is C. When ferrous sulfate is administered, it should be between meals, not with the meals, but on an empty stomach, and preferably with orange juice because vitamin C will aid in that iron absorption. For best results, iron should not be given with meals. Ferrous sulfate can cause constipation or turn your child's stools black. So make sure you're watching out for that as well, and for teaching the parents that so they don't freak out. With sickle cell disease, it is hereditary hemoglobinopathy, and primarily affecting African Americans. It's characterized by the partial or complete replacement of normal hemoglobin with an abnormal sickle cell shape, kind of an S shape. And so you can see here on this PowerPoint the normal flow of red blood cells. They're nice, they're plump, they're big, they're round, they look good, they just kind of slide on past. But with the sickle cell, what happens is they, because of that S shape, they clump up together. And when they clump up together, that actually obstructs blood flow and causes ischemia. We know that with ischemia, it causes pain. And so with this disease, it can cause severe pain. Factors that contribute to sickle cell crisis are going to be fever, dehydration, altitude, extremes in temperature, vomiting, emotional distress, fatigue, alcohol consumption, pregnancy, elevated hemoglobin levels, elevated reticulocyte counts, excessive exercise or physical activity, and acidosis. So any of those things are going to cause a crisis in this person. Sickle cells can resume a normal shape when they're rehydrated and reoxygenated, and the cell membrane becomes more fragile and the cell life is shortened from 10 to 20 days instead of the normal red hemoglobin days of 120. So you can see they're falling off fast. With our assessment, we're going to take a history of the sickle cell trait. We're going to report any kind of pains, crisis management, assess for acute or chronic pain. Fever is an emergency and will require urgent treatment. Hemoglobin electrophoresis verifies diagnosis. Sickle death screening will be done on a finger stick, and the most common reason for hospitalization of a child is due to acute painful episodes. Sickled RBCs cause a vaso-occlusion where blood isn't getting down to the limb, microinfarction, and ischemia. And just the same way we talked about an MI occurring and blocking that blood flow. If that blood flow is blocked, it's going to cause ischemia, it's going to cause necrosis, it's going to cause pain, and that's exactly what happens here. So with that, we are going to rehydrate them. We're going to give them some pain medication and give them some oxygen as well. The pain will typically happen in the back, the abdomen, the chest, and the joints. Those flat bones, that's where red blood cells are reproduced. So it assists with hydration through IV fluids and oral intake, increase tissue perfusion by administering oxygen and blood products as ordered, encourage rest, administer analgesics around the clock when in crisis, position for comfort to decrease any kind of stress on those joints, and encourage passive range of motion exercises to prevent any kind of venous prevent infection, frequent hand washing, and give prophylactic penicillin as well. With this, we're going to teach them to follow the plan of care as prescribed to prevent any kind of stress, prevent hypoxia from physical and emotional stress, provide that adequate rest, as well as avoiding extreme temperatures. With hemophilia is going to be referring to a group of hereditary bleeding disorders resulting from a deficiency in specific clotting factors. There is no cure, and it is a lifelong condition. So basically, this person just cannot clot. They bleed and bleed and bleed, and they are not able to clot. There's several different breakdowns of hemophilia. Classic hemophilia will be the hemophilia A. It's caused by a deficiency in factor 8. Hemophilia B is a deficiency in factor 9. A and B are both X-linked recessive traits, which are most oftenly expressed as exclusive carrier females. However, they affect the males. So it's a mother is the carrier, and it usually affects her son. The degree of bleeding is going to be related to the amount of clotting factor, which is dependent on the phase of coagulation affected and the severity of the injury. So with these people, we're not going to suggest them going out and playing football. We want to try and protect them from that, make sure that they're not in aggressive sports or anything like that. And so with a question like that, you have maybe options of what would be an appropriate sport for this person to play. Obviously, we're not going to do anything contact, so maybe swimming is going to be a good choice for them. Bleeding can be mild, moderate, or severe. Symptoms may not become evident until about 6 months of age, when the infant becomes more mobile and begins tooth eruption. Hemoarthrosis is bleeding into the joints. It's one of the most common symptoms with bleeding in the knee, ankle, and elbow joint. And of course, we need to assess for joint deformity after this as well. Diagnosed by history, presenting symptoms, physical exam, and then we will do a huge breakdown of labs. Prolonged PTT, decreased factors of 8 or 9 levels, PT, thrombin time, fibrogen, platelet counts are all normal. And you can see a breakdown on 824 of just kind of the mechanism of the formation of a clot and how complex that is and what all goes into it. We'll be assessing for hematuria, flank pain, complete a neurological assessment to determine complications related to intracranial bleeding, and assess for ecchymosis. Replacement factor contamination is reduced by careful screening of donors. Hemophiliacs who have received some of the more impure forms in the past could actually be at risk for developing AIDS. The goal of medical management is going to control that bleeding by replacing the missing clotting factor. With this patient, we don't want to do any rectal TIMs. We're going to manage pain using analgesics, immobilize, elevate, ice that affected joint, and after bleeding is controlled, range of motions are going to be performed to strengthen those muscles, the joints, and prevent any kind of contractures. Goal of medical management is to control bleeding by replacing the missing clotting factor, control bleeding for significant bleeds through administration of necessary replacement factor, monitor those factor levels as ordered, transfuse as ordered to prevent minimize any kind of disease complications. Whole blood will help replace the blood volume. Pressure pros and plasma will actually expand that blood volume. Chiropracticipate, I screwed that word up, replaces that factor 8 and factor 9, and Willebrand's factor and fibrogen. So there's several different mechanisms that all go into hemophilia and the clotting factors. Yes, DDAVP may be administered to children with mild hemophilia A, and it increases the level of factor of 8 and von Willebrand factor. Again, our treatment plan, what we need to do for these patients, relieve their pain, prevent joint contractures, prevent injury, provide family teaching, and promote family coping as well. That mother might feel very guilty. Okay, so the nurse is caring for a 10-year-old boy with hemophilia. He asked the nurse for suggestions about appropriate physical activities. So which physical activity would the nurse most likely recommend? Baseball, soccer, football, wrestling. Which one has the least amount of contact in it? baseball. Children with hemophilia should stay active. We don't want to encourage them not to do any sports, but good physical activities would be swimming, baseball, basketball, bicycling. Of course, use a helmet. Hopefully they have better balance than I do. And you would still need to be careful about falls and sliding into bases and things like that. However, intense contact sports, football, wrestling, soccer, all of those should be avoided. Okay, second question. In hemophilia A, the classic form, only females manifest a bleeding disorder. Is this true or false? It is false. Remember, the mom carries the trait, but it passes on to the boy. So the classic form in the hemophilia is caused by deficiency of coagulation, component factor 8, hemophiliac, anti-hemophiliac factor, and transmitted as a sex-linked recessive trait. So incidence is approximately 1 in 10,000 white males. Female carrier may have slightly lowered but sufficient levels of the factor 8 component so that she does not manifest a bleeding disorder. Males with the disease also have varying level factors. Their bleeding tendencies varies accordingly from mild to severe. Got another one. Lots of sickle cell questions. You care for a 4-year-old with sickle cell anemia. Physical finding you might expect to see in him or her. So remember, sickle cell anemia, what does that cause? Think about it. A enlarged mandibular growth, depigmented areas on the abdomen, increased growth of those long bones, or D, slightly yellow sclera. Okay, the answer is going to be D, slightly yellow sclera, and with this, many children with sickle cell anemia will develop this yellowing of the sclera just from that excess bilirubin. We know that excess bilirubin causes jaundice, and it's just a breakdown of all those damaged cells. All right, there we go. We're all done. Thank you, guys. Make sure you look at the nursing processes and check out leukemia. We didn't really get into that one either, but you will see children up on the floor with leukemia. The leukemia, of course, it's just, it is one of the most common types of cancers that you're going to see in these small children in the pediatric units. More than likely, you've probably even seen some kids come in with that. They might have done the intrathecal chemo. So just read through that, look through it, and you guys should be good to go. Thank you.